My name is Amy Green. I am a medical retina optometrist at York Teaching Hospital. A little bit about me, I have 3 jobs at the moment. So I work for Bradford, I teach at Bradford. I teach the medical retina professional certificate at Cardiff, and my real job is I work in medical retina. So we've been talking about different medical retina conditions that you might encounter in primary care. We started off with wet macular degeneration and dry macular degeneration, and some of the things that we might do in practice to help identify the patients that are at risk of sight loss. If you've only got dry macular degeneration, I want you to start thinking differently about it, because there's such a variation of risk for these patients. Few small hard drusen, the risk of it changing in 5 years is about 0.4%. Medium drusen, 2 to 20%. Pigment changes, that puts you higher up the risk category. When they start getting to this medium drusen size, I'm starting to think, what else is there as well? You're seeing a patient in practice and you're thinking, well, how am I going to measure whether it's a medium, a large or whatever? So large drusen are about the width of the vein as it crosses the optic disc. This patient was also a smoker, and they had this family history of vision loss. Their mother had it, okay? So there could be some genetic element going on there. A lot of the treatments now are expanding. We've been treating wet AMD with Eylea anti-VEGF treatments for quite some time now, and we're getting the newer generations of the drugs through, and so it is an expanding field because we've got an ageing population and we're seeing a lot more patients. Especially as a lot of the treatments for the dry macular degeneration are being investigated. There are treatments available in the United States which didn't quite get through NICE here. They didn't meet the criteria, but at some point there will be, in which case the 10% which we are treating at the moment, which is the wet macular degeneration, is going to turn into 100%, which is when we include that dry macular degeneration cohort, which that's going to be a busy time. There's a lot of research going into a lot of different things, and it will be interesting in the next few years. It's going to expand dramatically, I think. And I want you to start thinking about whether you want to monitor these a little bit more closely. So at the minute, what we all do is we go, here, have an AMSLA grid, see you later. Yeah. The EDNA study, which looked at how to monitor early macular degeneration, they looked at whether AMSLA was useful or not. And actually, in some cases, it's the best thing that we have for doing that. But OCT is much more accurate. So the EDNA study found that OCT sensitivity, which is correctly identifying a positive result, was 92%, and correctly identifies a negative result 88%. So that's pretty good. So OCT detection, pretty good. It's definitely changed a lot from when I started. The detail has increased massively, and we now have a huge array of biomarkers that we can use to try and identify what is going on in an OCT, and whether we need to be thinking about referring them, whether we need to be talking to patients about different risk factors. And there's a lot of things that we can actually talk about in primary care that may reduce people's risk of developing things like late stage macular degeneration, such as wet macular degeneration or the geographic atrophy. And certain signs, if we can identify those, we can have those conversations early and try and either reduce the risk of developing the wet macular degeneration, or in some cases possibly prevent the macular degeneration in the first place. It's a lot of looking at OCTs. After a while you can just start seeing them, but being able to identify the features first of all is the first step really in managing patients. You've got a very thin line here, and that's Bruch's membrane, and then above that you've got a little separation, and then you've got the RPE. But if you see that sign on a dry macular degeneration patient, that's something called a double layer sign. So it's this long flat pigment epithelial detachment with hypo and hyper-reflective areas within it. That's a double layer sign. So that is quite highly indicative of something called a non-exudative choroidal neovascular membrane or macular neovascular membrane. So these non-exudative ones, they're floating around in the community, and actually they can start leaking. So they're the ones that are high risk. If you look at the diabetic screening service, for example, they're obviously trying to pull out people that are at risk of sight loss. Whereas what we're missing is this whole cohort within the sort of dry AMD population that are highly likely of losing sight, and they lose sight quicker. We want to be able to identify those people that are at risk, just like we would in a diabetic screening service, and pull them out of the population so that we can identify them and get them early treatment, because early treatment preserves the vision. And ideally we want to get that before it gets to that 6/12 level, because that's going to stop them driving. Tubulations, has anybody heard of that term? They're important to differentiate from intraretinal fluid. So this is a tubulation. So it shows up on the OCT as a dark area with a hyper-reflective border around it. They kind of form this ring, and it's to protect themselves. And it's usually over an area of disruption in the RPE. The photoreceptors, they kind of curve round, and it's a protection mechanism, we think. But it's often over an area of disruption of the RPE, and unfortunately it's quite a poor prognostic factor, but it can be mistaken for intraretinal fluid. So you have the hyporeflective centre with the hyperreflective border, whereas in the intraretinal fluid you would only have the hyporeflective area. It's important to distinguish them, because one of them you would treat it and one of them unfortunately you can't, which is the tubulations. All AMD patients, you want to discuss the AREDS2 supplementation. We know that in patients with advanced macular degeneration or intermediate macular degeneration, which is this medium drusen or one large drusen, these are the ones that benefit from the AREDS supplements, especially if they haven't got a good diet. Obviously, stop smoking. Yeah, everybody needs to stop smoking, just don't do it, it's not a good idea. Advise the DVLA if it's affecting both eyes. Home Amsler grid, with the caveat that, try and do OCT if you can. And you want to consider referral for magnifiers. Some of them can have a really good vision. You look in and you think, don't like that. Actually, what you want to be doing there is getting them lighting, because the quality of that vision isn't very good. And discuss diet. This is probably one of the most important things you can do. So if you look at the eye disease case controls study, the top quintile of vegetable intake reduces the risk by the same amount as the AREDS study, which is about 25%. So and especially if you've got those two genes that I was talking about before, it can massively reduce your risk. So eat your greens and all the other colours as well, please.